Almost there.
It's showing up that we're live now on my.
Yeah, it takes an extra like 20 seconds to actually go through.
Got it.
So we're almost there. The final spinning. It's so close. My Wi-Fi is starting to collapse in the last few days of the semester. Okay, and we are live. Good afternoon, everyone. Thank you all for joining our session today. We have the pleasure of hosting Dr. Malik, who specializes in urology. And as always, please remember the Google form will be posted in the chat box, in the YouTube chat box at the end of the session for you to mark down your attendance. So with that being said, Dr. Malik, you can get started whenever you're ready.
Hi, everybody. Thank you so much for joining me. My name is Dr. Rena Malik. I am Assistant Professor of Urology in the School of Medicine at University of Maryland. I also subspecialize in what's called female pelvic medicine and reconstructive surgery. And I'll talk a little more about that. So what is a urologist? It's a specialist who takes care of both the medical and surgical care of the genitourinary tract. And so what does that entail? Well, we take care of kidney issues, particularly the plumbing of the kidney, whereas medical issues of the kidney are taken care of by nephrologists. We also take care of the ureters, which are these tubes here that drain the kidney, as well as the bladder. In men, we take care of the prostate, as well as the urethra and the genitals as well. In women, we also take care of occasionally the pelvic floor and pelvic organ prolapse, so related to the uterus and other genital, or and the vagina and vulva and the other genital organs. If you decide to go into urology, you can actually even subspecialize. Even though we are such a very small specialty, you can subspecialize in a number of different things, including cancers of the genitourinary tract. So that most commonly includes prostate cancer, kidney cancer, bladder cancer, testicular cancer, and rarely penile or adrenal cancer. You can also specialize in endourology, which is primarily stone disease. So when people get kidney stones or stones that obstruct the ureters or tubes that drain the kidney. You can also be a minimally invasive urologist. So urologists are some of the first surgeons who did robotic surgery. So we do a lot of robotic surgery for a number of different things, including cancers, non-cancer surgeries. So you can specialize in that. You can do pediatric urology, so you can take care of children who have urologic needs because they were born with congenital abnormalities that need repair. You can also do reconstructive surgery and prosthetics, which predominantly includes male urethral stricture disease, or if you have prosthetics like penile implants or urethral sphincter implants for men who have leakage of urine. You can do male infertility or male and female sexual dysfunction also fall into our purview. And then lastly, like myself, you can do female pelvic medicine and reconstructive surgery and neurourology. So I take care of a lot of different things, which can include leakage of the bladder, overactive bladder, which we're going to talk about today, as well as pelvic organ prolapse for women, urinary problems for patients with neurologic diseases like spinal cord injuries, multiple sclerosis, Parkinson's, and any problems with voiding, essentially. So today we're going to talk about urinary incontinence. And to start that off, we'll talk about types of urinary incontinence. The first type we'll talk about is urgency urinary incontinence. And what that is you may hear people or yourself may sometimes you get your key in the door when we used to actually have keys in doors, and you get the urge and you got to rush to the bathroom, or you find yourself kind of just living in the bathroom all the time. And this is what's called overactive bladder. It's that sensation that you gotta go. You're going every 15 minutes or very often. Normal frequency is anywhere between 4 to 8 times, and more than 8 is considered abnormal. Being up at night to use the bathroom is called nocturia, and not being able to make it in time, so having leakage of the bladder because you can't make it to the bathroom in time, is called urgency urinary incontinence. And what causes it? So normally, this is your bladder here, and when your bladder is full, that gives your brain a signal that you are ready to go use the restroom. It tells it, you then get the urge, and your detrusor muscle contracts when it's full. But when you have overactive bladder, your detrusor muscle contracts before the bladder is full, giving you that urge to rush to the bathroom, and sometimes you have leakage. This is associated with a lot of different things. So you can see that it's associated with age. So as people age, their bladder does tend to get more overactive, and they can have more of these symptoms. With fluid intake, so if you're drinking a lot of fluid throughout the day, as I am, you will find yourself urinating more frequently, and that's expected. Certain things like caffeine can be bladder irritants and make you go to the restroom more often. They're also a diuretic, which means that they make you make more urine than what you drink in. And alcohol is also a bladder irritant. So drinking alcohol can, again, have that same diuretic effect. So you're making more urine, but it can also irritate the lining of the bladder so that your bladder squeezes before it's ready. Certain medications can also cause this problem. So certain medications that you might take for blood pressure may make you make more urine than you're drinking and make you have that urge more commonly. And lastly, pelvic organ prolapse, which is where you have, this is a sagittal view or a cut of the body. And here is the pubic bone. Here is the bladder. Here is a woman with a uterus. This is the vagina, and this is the rectum. And if you have a prolapse of your anterior vaginal wall where your bladder is falling out or herniating through the vagina, then you can have some of these symptoms because your bladder is stretched out and causing these symptoms. Another type of incontinence is stress urinary incontinence, and this is leakage that occurs when you cough, sneeze, exercise, you get up from sitting, or even during intercourse. And this is distinctly different, has a different cause for it than urgency urinary incontinence. But you can't have both at the same time. And while I teach you that these are two separate entities, many people come in with mixed urinary incontinence, meaning they have both stress or urgency urinary incontinence. And this is caused by two different things. So here you have urethral hypermobility. So this urethra actually moves when you have abdominal pressure, and that's because the pelvic floor support, or those muscles that are underneath the urethra, are weakened. And that can cause leakage, or the sphincter itself, which is inside the urethra, can be weak, and that can make it difficult for you to keep urine in when you're having any pressure abdominally. And so what causes this? Pregnancy is a big cause of stress urinary incontinence. If you're doing very high intensity training, squatting, CrossFit type activities, this can weaken your pelvic floor muscles. If you are overweight or obese, this can also cause this. Smoking is twofold. One, it causes weakness in the pelvic floor, and two, it causes a chronic cough, which, so if you have weakness already, it will make you leak more because you're coughing all the time. And also certain disorders and other things can make you at higher risk for stress incontinence. Intrinsic sphincter deficiency, where I said like the urethral sphincter is weak, is more common in older patients if they've had previous surgeries, or if they've had pelvic radiation for cancer or other previously, like cervical cancer, vaginal cancer, prostate cancer. Those sort of things can cause intrinsic sphincter deficiency. And lastly, I'm not going to talk about this one too much, but it's called overflow urinary incontinence. And this is when someone's bladder is so full that their bladder can no longer hold any more urine. And the pressure within the bladder, which is like a balloon, it will continue to expand, but at some point the pressure within the bladder gets so high that actually leaks through the urethra and causes leakage. And the reason they say blockage here is because very often it's associated with having a prolonged blockage that then causes urine to build up and back up in the bladder. Also, if your bladder doesn't squeeze well, and that can be from neurologic disease or prolonged diabetes, then you can also have difficulty emptying your bladder, or if you have any other neurologic disorders. So the way to think about the lower urinary tract is to think that you have either a problem with your bladder or a problem with your outlet. And so the bladder can have issues like not squeezing well, or you can have a problem with a blockage here. And those can be the reasons for any type of incontinence. So moving on, just to let you know, nearly half of people who are over 65 will suffer bladder disease. Half. That's a lot of people. A third of women 30 to 60 years of age have incontinence. And only 1 in 4 of those women will actually seek care, because a lot of people have these myths that think that this is just a normal part of aging. I just have to live with it. And they don't give themselves the priority to take care of these things. And less than 50% of those women actually receive some sort of treatment. If you look at the most chronic conditions in the United States, you'll see that incontinence is just above diabetes. And this is just incontinence. If you think of those symptoms like urgency, frequency, nocturia, that's going to be even higher. And so it's up there with some of the most common chronic conditions in the United States. In the US, they've actually looked at the prevalence of overactive bladder specifically, and it's 16% have some symptoms of OAB. Depending on the study you look at, I've seen some that have been as high as 40%. And it does increase with age, but you'll see that even at lower age groups, you will find men and women with OAB symptoms. And when you look at the spectrum of incontinence and OAB, as I mentioned, you can have mixed incontinence, you can have urgency incontinence, you can have stress incontinence. And this category of overactive bladder fills this whole big circle right here, which would be urgency, frequency, nocturia. This would be dry overactive bladder, and this would be wet overactive bladder. And, it's more than just having incontinence or access. It has real impact on the quality of life. I see many patients who tell me they can't go outside the house, or they have to go places where they know where the bathroom is. They don't go to movies anymore. They avoid having intimacy or sexual contact. They take days off work because they're embarrassed of how much they're having leakage, or how they can't even sit still because they have to go to the bathroom so often. They often, it's a big financial burden. They have to buy pads or chuck pads to sleep on. They have to do lots of laundry. And then of course there's a psychological component. So patients feel very, suffer some self-esteem issues. They worry about being a burden. And these can have real impacts on their quality of life. So there's multiple barriers to treatment. As I mentioned, there's patients who have some misconceptions that it's normal. It's not really a big deal, or it's not severe enough. They're embarrassed to come talk to a doctor about this. And if you decide to go into medicine, or you are in medicine, you decide to, if you don't ask about it, they will not tell you, because they're embarrassed and they're worried that the treatment won't help them, or they're scared that the treatment is very invasive and they don't want to even consider it. In healthcare professionals, this is obviously what I do for a living, but I think this is so important for all healthcare professionals. But one, there's really no great tools. Like, we're not giving them a form at the beginning of their visit to say, hey, do you have incontinence? Yes or no, check a box. And, so it's hard as a provider to ask these questions, and there's multiple other boxes to check, right? If you're a primary care doctor, you have to make sure their heart and lungs are safe and their kidneys are good and their diabetes is under control and all sorts of things, whereas incontinence comes later down the line. So our first case, our only case we're going to actually talk about throughout the thing, is we have a 44-year-old female with urinary incontinence. what kind of information or what kind of questions would you ask to differentiate what type of incontinence she has? I'm going to look at some of the questions here. Rigorous exercise like CrossFit, does that cause this over time? Well, we don't really, I can't tell you that everyone who does CrossFit is going to have problems with their pelvic floor, but certainly if you are having a weak pelvic floor, it will worsen it. What can you do to strengthen your bladder if you drink coffee and water a lot? Well, it's not about strengthening your bladder. It's that some people's bladder will be more sensitive to coffee or lots of fluids. I tell people if you're drinking a lot, try to sip on fluid rather than having to take big gulps, because that will help have less urgency. And coffee, you can try decaf, you can try other things. Some people are not bothered by coffee and some people are. So I see some great questions here. How often does she go to the bathroom? When does she go? How often? What causes it? When does it occur? Exercise, medication, what activities are causing it? Family history. Great. These are excellent questions, guys. Really great. So she tells you, I can't hold my bladder at all. She starts leaking on her way to the bathroom. She doesn't really notice it's associated with specific activities like coughing, sneezing, or lifting heavy things. She finds that she's going to the bathroom almost every hour and a half. And it's been going on for about 4 months. She's using 4 pads per day. So if you ask her how many pads she's using, and 2 pads per night. The important thing about asking if they're using pads is how many pads are they using, but also what kind of pad are they using? Are they using a liner? Are they using a maxi pad? Are they using a Depends? And how soaked is it? Because some people will change them just if they get a little damp because they don't like feeling it wet in their underwear, whereas other people will wait until it's pretty saturated. She also wakes up 3 times at night. And specifically when you're asking about waking up at night, you want to ask, why are you waking up? Are you waking up with the urge? Are you waking up for some other reason and then you're going just in case? Because a lot of people do that, and that's not necessarily caused by a bladder issue. That's caused because you're habitually or convenience voiding to avoid having to pee later. She also has a past medical history of diabetes and a past surgical history of a mid-urethral sling. And a mid-urethral sling, we'll talk about later, is a treatment for stress incontinence. And that will be important. Basically what it is a small piece of mesh that goes underneath the urethra that provides support to help leakage with coughing, sneezing, or lifting heavy things. But you can think about this as, hey, there's something underneath the urethra. So that could affect how urine flows through the urethra. So keep that in mind as we go through this presentation. So now we're going to go on to diagnosis and evaluation. You want to ask them specifically, as many of you have mentioned, what are their symptoms specifically? Like we delineated some of them. How many episodes are they having? Is it happening during the day? Is it happening during the nighttime? And again, we talked about degree of leakage, types of pads, and number of pads. You also want to ask them what their voiding pattern is. Are they straining to empty? Is it come really strong, or is it kind of weak? Do they have to wait for their stream to start, and when it starts, does it stop and go, or is it pretty straight? And for a lot of women, you might say, hey, are you leaning forward to urinate? Or are you pushing on your belly to urinate and get that urine out? And very important in these patients is what are they drinking? And then most important is how bothered are they? Because at the end of the day, most of these things, again, not all incontinence is not dangerous, but most of this incontinence is not dangerous to their health. And if they're not bothered, then you don't need to stress them out or do any further evaluation as long as you rule out anything dangerous. You also want to assess their pertinent history. What's pertinent for incontinence? Well, if you think about the anatomy, the bowel or the rectum sits right behind the bladder. And so that can be, if that's full, if you have constipation or you have like inflammatory bowel disease, that can push on the bladder and cause bladder symptoms. Sexual function is also important to identify if they're having pain with sex, because that may point to other diagnoses. Have they had children, if they're women, and how were those babies delivered, vaginally or via C-section? And were there any complications with those deliveries? Did they have to have forceps, or did they push for a really long time? And did they have a large baby? How big was that baby? What medications are they on? And then, of course, you want to assess their neurologic history. A lot of these things will, like the neurologic history, you'll get from the past medical history when you ask that. Medications. This is a long list of medications that can affect incontinence. The most common ones that I see in everyday patients are diuretics. So patients who get diuretics for congestive heart failure or high blood pressure, they can have they can make a lot more urine, and that can cause their incontinence to be worse. If patients are on narcotics, they can actually have a difficulty emptying their bladder. So that may point you to overflow incontinence. And what I didn't circle here, this is particularly, I see this a lot, is anticholinergics, because I see a lot of patients who have Parkinson's disease and may also have other anticholinergic medications that can make it difficult for them to empty their bladder as well. ACE inhibitors is another thing where people sometimes get a cough, and they can then have stress incontinence associated with that cough. So here, my animation didn't work. So other questions to ask. So we found out that she uses 2 pads per day and 1 pad per night. She denies constipation and has 1 soft bowel movement a day. She drinks 2 cups of coffee daily, 2 glasses of water, and a glass of wine before bed. She denies any neurologic history. She is sexually active. She doesn't report that she has any pain with intercourse or leakage with intercourse. She's had 2 vaginal deliveries, no complications, and her diabetes is well controlled. Do you guys have any idea why I'm asking about her diabetes being well controlled? So I'm just looking if there's other questions here. Okay. Diabetes makes you pee because of extra glucose. Very good. Very good. So diabetes is certainly related, because the more sugar you have in your bladder, because when you have diabetes, when we test for diabetes, you will check sometimes and you will find glucose in the urine. And if you have glucose in the urine, it will make you urinate more frequently. It also has long-term impacts on bladder function. So in the beginning, when they're diagnosed with diabetes, they will present with overactive bladder symptoms, and improving their diabetic control can also help with those symptoms. If they have diabetes for 10, 20, 30 years, their bladder actually gets weaker over time, and they may have difficulty emptying their bladder. So now moving on to her physical exam. When we do a physical exam, you want to look at the skin changes around the vagina and particularly the vulva. So you want to assess if there's whitish colored tissue that may be concerning for things like lichen sclerosis that could mimic some urgency or could cause urgency frequency. Also, you can see if there's tenderness in that area, which may cause symptoms such as pain or urgency frequency. Other factors that might contribute would be like vaginal atrophy, pelvic organ prolapse, urethral diverticulum, which are little cysts that are underneath the urethra. You can assess perineal sensation and to see if they may have an undiagnosed neurologic disorder. And importantly, very often I find that a lot of patients have what's called pelvic floor dysfunction. So if your examining the vagina and you palpate the muscles in the vagina, if they are very tense, this is actually a big cause of symptoms. And so if you think about it, the pelvic floor is this bowl of muscles that holds up all the organs. So your bladder, your rectum, your uterus for some people, and they're right inside the vagina. And if they are tense all the time, then they are flaring up all those organs. So you can have urgency, you can have frequency, you can have pain with intercourse. And often you can find that these symptoms are correlated with how stressed you are. So you can see people get TMJ where their jaw gets really tight and clenched. It's the same thing. You can hold stress in your pelvic floor. Both men and women can have this problem, and it can create all of these symptoms. And you will never know because it's not like there's a way to check your you're not yourself checking how tense you are in your pelvic floor. It's very common in type A personalities, people who are very anxious, very stressed. And then again, doing a focused neurologic exam and a rectal examination. So diagnostic tests for all patients, I recommend a urinalysis and a post-void residual. What is that? So when they urinate, when we have people come to our clinic and urinate, we have them empty their bladder, we have them come to the clinic, and then we scan their bladder with a little ultrasound probe that can tell us how much urine is left in their bladder. This isn't required for all patients, but if they say, hey doc, sometimes I feel like I'm not emptying my bladder well enough, I'm straining to urinate, I'm bending forward to urinate, and sometimes, to be quite honest, I've found patients who just say they have urgency frequency and they have a high post-void residual because they've had many years of holding their urine and not emptying, and they've just gotten used to holding more urine over time, and so they'll have an elevated post-void residual. And doing any sort of other non-invasive treatment or workup, you may not need anything more than that. But if you decide to further investigate, particularly in urology, we do some other testing. So this is other causes. Overactive bladder particularly is a very complex problem, and it can be caused by a number of different things. You want to rule out infection. You want to rule out cancer in the bladder. You want to rule out any obstruction of the bladder outlet. If they have obstructive sleep apnea, that can affect their bladder function actually. And we've shown that improving sleep apnea can improve their waking up at night to urinate. If they have certain medications, you can work with their primary care doctor or their cardiologist to change the timing of those medications, or maybe change the type of medication so they have less worse urinary symptoms. Is that, yeah. So in urology, the other diagnostic workup that we do are things like cystoscopy, which is a small camera that we use that goes into the urethra, inside the bladder, so we can look inside and rule out any sort of bladder cancers, rule out any sort of stones or abnormal things, and particularly if people have had surgery with mesh or other issues, you want to do a cystoscopy. Urodynamic evaluation, I'm going to talk about a little bit more, as well as you can sometimes consider further imaging of the lower or upper urinary tract. That means the bladder or the kidneys and the ureter, depending on what you are trying to find out, specifically for those who failed first-line treatment options, or if you're worried about a GU malignancy or some sort of bladder outlet obstruction causing the overactive bladder. So the one thing to know about overactive bladder is that if you are obstructed for whatever reason, before you have difficulty urinating, your bladder will be trying really hard to push urine past that obstruction, and you will present first with overactive bladder. And so in men who have large prostates, or women who've had surgery that might cause it be difficult for them to empty their bladder, they may present with overactive bladder. And so for those patients, you may want to do further testing. So why do urodynamics? Well, it's very helpful in identifying the diagnosis. It can help you with prognosis in certain cases, as well as guide what treatment you think is best for them and how to evaluate, potentially if you do it after you do some treatment, you can evaluate their success. So urodynamic evaluation, what it is essentially is we put a small catheter in the bladder, a small catheter in the rectum, and little EMG patches on the perineum. And we fill the bladder slowly with fluid. And during that time with these other catheters, we can measure the pressure in the bladder, the pressure in the rectum, which is essentially your abdominal pressure. And when we subtract these two, we get a true detrusor pressure. So we can do it during filling and during voiding. And this is exactly what you would expect during voiding, is that your bladder pressure goes up and comes down, and you void this nice, beautiful bell curve here. And you would expect during a normal filling that your detrusor pressure would be completely flat, and there would be no overactive contractions, which would be like kind of big loops here, or if you have them bear down or cough or that you would not see any leakage. If you had them bear down and cough, you'd see a big spike here. Here you can see these are probably coughs, and you would see leakage on the flow if they had stress incontinence. If they had overactive bladder, you would see essentially kind of big, big mounds here where your bladder is pressure is going up and then comes down, and that may or may not be related with leakage. It could be just that's when they feel the urge to urinate. A question I got was, is urodynamic evaluation painful? So no, the catheters are very, very small. It's not painful, but it is uncomfortable to have this test. It's usually with a physician or a mid-level provider and a nurse in the room. So you're sitting there, you have all these catheters in, and they're attached to a machine. So it can be a bit embarrassing, and it can be, slightly uncomfortable to get the catheters placed, but it's not painful. But you do have to be very thoughtful when you're doing these sorts of things, because it is, we're dealing with very sensitive things for patients, and they're for lack of a better term, exposed. And so you have to really be thoughtful when you're doing these sorts of things, and be careful when you do them and not do them unnecessarily. So as I mentioned, it does provide information about the voiding pattern. It also, during that filling, will tell you how big the bladder is. So how much fluid can that bladder hold? Compliance is a measure of how elastic the bladder is. So a normal bladder should fill slowly and should be very elastic, like a balloon. And if it's not that way, or it's stiff, that would be maybe a sign of neurologic injury and may be concerning. It will tell you about sensation, because this is not done with patients asleep. They are awake. So during the test, I will ask you, how do you tell me when you feel something in your bladder? And if you were driving, when you would say, hey, I'm going to take on a highway, I'm going to take the next exit, versus when you're going to tell me, I'm going to pull over on the side of the road, I have to go really badly. And that's going to give me a sense of what your sensation is like. We'll also see, again, how well your bladder contracts during emptying, as well as, does your bladder have unstable contractions, or those detrusor overactivity contractions during filling? And then, can you control your urine when you cough, sneeze? We won't have you sneeze, but cough or bear down. Can you keep your urine in, or does it leak? You can also find, does your sphincter relax? So when you urinate, your bladder squeezes and your sphincter relaxes. And so with those EMG pads, you can see if the sphincter relaxes as it should when they're voiding. And then again, you can assess if they've responded to certain types of treatment. And you can add with this a video component, and instead of filling just water in the bladder, you can use contrast in the bladder and then take x-rays at the same time. And this can be helpful, particularly in neurologic patients who may have this more stiffer, more poorly compliant bladder. So we're here back again with this 44-year-old female with urinary incontinence. We did a post-void residual. It was only 60 cc's, which is okay. 30 cc's is an ounce, and 1 to 2 to 3 ounces is probably reasonable to have a post-void residual, but you do have to take it on a case-by-case basis. Some people will walk around with a post-void residual of 300 and not have any issues, and some people walk around with a post-void residual of 150 and have a lot of issues. So it's really case by case. Urinalysis is negative, so she does not have a UTI, and she does not have blood in her urine, which might be indicative of a cancer or other issues. So what do you guys think after we went over this? Does she need urodynamics or cystoscopy? And while you guys answer, I'm going to answer some questions here. Is certain fluids irritate your bladder, but are there specific foods that do the same? Are there any that are bladder friendly? That's a great question. I don't think that there are specifically items that are bladder friendly. Certainly water is not going to irritate. There are things that are not going to irritate your bladder, but there's not things that are like really great for bladder health. I think in general, keeping a very healthy diet, clean eating is helpful for many issues in medicine. And so I just recommend that to my patients, but I do tell them that if they're having overactive symptoms and they have a lot of one thing in their diet, try to omit that one thing and see if things get better. And it does help for a lot of people. So let's see what you guys said about this. Yes, so I've got 4 yeses. Awesome. So she does need urodynamics and cystoscopy because she had a history of a mid-urethral sling. And as I mentioned, that sits underneath the urethra. And if that is gotten too tight, then she could be obstructed. So we need to assess for the presence of bladder outlet obstruction. And because it's a sling and it's made of mesh, there are rare cases where that mesh can erode into the bladder. You can imagine if the mesh erodes into the bladder, then you can have, irritative symptoms because your bladder is trying to react to this foreign body. So she does have those. Her urodynamics does show detrusor overactivity during filling, but no evidence of bladder outlet obstruction. So one thing to note is if you send a patient for urodynamics and they don't see detrusor overactivity, that doesn't mean they don't have it. In fact, 40% of the time, you won't actually see detrusor overactivity during the examination. And that's okay. That doesn't mean they don't have overactive bladder, but the point of it is to rule out other dangerous things or other things that need to be corrected first. And she proceeds with cystoscopy, and there's no evidence of sling or mesh material in her bladder. So moving on to treatment. We start with non-pharmacologic treatments, and this includes, first, we educate patients on bladder symptoms. We talk about diet. I'm going to go through these individually. Time voiding can be helpful, particularly for patients who hold their urine for a long period of time. And I find this very often in nurses, teachers, hairdressers, drivers, like truck drivers or people who drive for a living. They tend to hold their urine for long periods of time for many, many years. And they can then get to a point where their sensation is a little dulled and they only feel the urge when they're super, super full. And so they're rushing at that point. So if they start putting a little timer on their phone or their Apple Watch or whatever they're using to remind them to urinate every 2 to 3 hours, that can avoid that problem. It's not going to work for people who are already going like every hour. In people who are going every hour, we'll do something called bladder training or delayed voiding, and we'll talk about that. They can also have pelvic floor exercises, which will help with bladder training. And so we'll talk more about that as well. The first thing is managing your fluid intake. So there are studies to suggest that if you decrease your input intake of fluid by 25%, you will decrease your urgency and frequency. So what I recommend to my patients is drink whatever you want with breakfast, lunch, and dinner. And then after that, you can have a 16-ounce bottle of water and sip on it throughout the day. And that will give you enough fluid to stay hydrated. And use your urine color to kind of guide you. It should be a light yellow, yellowish color, not dark yellow. And that will tell you that you're well hydrated. Avoiding bladder irritants. So I know some of you have talked about this. Coffee or caffeine are big bladder irritants. Some people can have less irritation with them. Some people have more. In fact, the only studies that we have look at really drinking a large amount of caffeine, like 450 milligrams of caffeine, which is the equivalent of a venti Starbucks coffee. And that was significantly more urgency and frequency compared to those who didn't drink that much coffee. Alcohol is also a bladder irritant, as I mentioned earlier. And for some people, the remaining things can be bladder irritants. It's not for everybody. So artificial sweeteners, carbonated beverages, acidic foods, spicy foods, or tomato-based products, these things can all irritate the bladder lining for some people. So I tell people, pay attention to what you're putting in your body and see if it affects your bladder. Other things is avoiding constipation. As I mentioned before, your rectum is right behind the bladder. So very often having them be on some sort of constipation regimen, specifically asking them what constipation means for them. So even if they're having a bowel movement every day, but it's super hard, they're constipated. It needs to be a soft, easy bowel movement. And so you want to work with them on managing their constipation, often adding fiber as well as some softening products like applesauce or prune juice can be helpful if they want to be natural. Stopping smoking, as I mentioned, is a bladder irritant. Time voiding we talked about, and weight loss. So it's actually been shown that 8% of weight loss reduction reduces incontinence episodes in nearly half of obese women. I'm going to put a plug out there. Tonight I'm doing an Instagram live with a weight loss physician to talk exactly about this problem. So if you are interested, join us because we'll be talking about it. I think it's at 7 p.m. Eastern Standard Time. And so you can check that out. Bladder training. So to talk a little bit more about this, when you have the urge to urinate, what happens is it starts, it gets really, really strong. And this is when we run to the bathroom. But if you wait, it will go away. So if you distract yourself and do Kegel exercise, quick flicks of your pelvic floor muscles, that can actually go away. And then you walk calmly to the bathroom and you will then retrain your bladder and brain to urinate at a more prolonged time and allow you to have more time. So I tell people, if you're urinating on every hour schedule, try to do this every hour for the first 3 days. Don't go less than an hour. Then extend it to an hour, 15 minutes, and do these exercises to help you get there. A lot of people don't know how to do Kegel exercises. So having them see a pelvic floor physical therapist can be really helpful in helping them kind of do this bladder training at home. Moving on, if pharmacologic treatment, if behavioral treatment doesn't work, pharmacologic treatment can be helpful. So I'm just going to think I have a chat question here. How often do I see urinary incontinence in adolescents and young adults? I don't see many adolescents or young adults in my practice because I treat adults, but I do see young people like in their late teens and early 20s who have urinary incontinence. And in young people, of course, in pediatric urology, there are plenty of kids who have bladder issues. So we do see it. I can't give you an exact percentage off the top of my head because that's not really what I see most often, but absolutely we see it in young people. So pharmacologic treatment is here. You could see the bladder has these muscarinic, this M here is muscarinic receptors, as well as these beta receptors. And then at the bladder neck, there are alpha receptors. So this is how, these are the receptors that are targeted with pharmacologic treatment. First off is anticholinergics. And anticholinergics, they competitively bind this muscarinic receptor that's on the bladder. And this receptor actually causes contraction. So when you bind to it, it blocks acetylcholine from binding to this bladder and limits contraction of the trusor muscle. So by using it, it will decrease the contractions of the bladder. It will decrease the number of episodes and the severity of urgency and increase bladder capacity. It will also increase the time between voids. These are very efficacious. So if you compare taking this versus taking a placebo, more people receive or go back to having continence or not having accidents when they take an anticholinergic. They also have fewer numbers of incontinence episodes, fewer numbers of micturitions per day, fewer numbers of urgency episodes per day, and a greater volume voided per micturition. And micturition is just voiding. Also, they do have some side effects, which do make it somewhat difficult for some patients to tolerate. So dry mouth is the biggest one. Also, people can complain of blurry vision or dry eyes and constipation. Also, impaired cognition is a big one, and so you want to use these with caution in elderly patients. Also, there is more and more data suggesting that there is a correlation between anticholinergics and dementia. So you do have to notify patients that are on this that there may be this correlation. We don't know that there's a causality relationship, but there can be a link. And so it's kind of, they have to use it if they understand that that is a possible risk. And then contraindications, you cannot use this in patients who have narrow angle glaucoma, gastroparesis, or if they have urinary, if they're not emptying their bladder, because this decreases the contraction of the bladder, it can actually make it harder for you to empty and put you into more retention. And so you don't want to use it in people who have difficulty emptying or a high amount of urine left over after they urinate. And you want to caution in using it in these patients who already have medications that have anticholinergic properties, particularly antidepressants, Parkinson's, Alzheimer's, and those sorts of things, because they can exacerbate that anticholinergic effect. So there's a number of medications available. They all are equally efficacious. They have different advantages and different cost points. So I will typically start people on oxybutynin extended release because it is the cheapest option. And there are reasons to pick one over the other. And, you know, for the most part, the big ones to remember are you want to avoid when people are worried about the acetylcholine effects, like the cognition or the dry mouth, dry eyes. You want to specifically pick medications that are either extended release or are more uroselective. In patients who are older, we'll tend to use things like trospium or Sanctura or Enablex, which have less crossing of the blood-brain barrier. And then pregnancy and other things will, depending on if they have issues with their liver or kidney, will depend on what kind of medications you will prescribe them. The big thing here is that 59% of people who are started on these medications will stop them by 6 months. 6 months. So you need to follow these patients up because they're probably more than likely not going to keep going with them. And if you stop asking them about their leakage, they're just going to continue having all the issues related to incontinence, and they're not going to be very happy. So there's another medication option. Currently, there's only one available that's FDA approved. It's called mirabegron. It works here on the beta-3 receptor, and it mimics this norepinephrine, so it's a beta-3 agonist, and it increases bladder capacity by activating the beta-3 receptor here, which causes detrusor relaxation. This decreases the sensation of urgency and increases the bladder size. It does have some side effects, but they're really minimal. So some people, about 10% of patients may have a very small increase in blood pressure. Some people complain of a stuffy nose or headaches, but I have never actually had a patient discontinue it for side effects to date, because usually the benefits far outweigh the side effects. You do need to caution with certain medications because it can interact with them. So this is the actual part of the handout that I give my patients in clinic. I say, here, you're here, we're going to talk about, you're here for evaluation. These are your conservative options. If you take a medication and you've tried some conservative options, you want to try it for at least 6 to 8 weeks. It says 8 to 12 here, but I will usually let them try it for a good 6 weeks. For some of these patients, they will not see a difference in their treatment until they've taken it for 6 weeks. So I will have patients come back to see me and they'll say, I really didn't see any benefit until 6 weeks after. And then I have them come back for a reevaluation. So this lady, she tried to reduce her coffee intake. She did do some bladder training. She tried oxybutynin XL 10 milligrams daily for a full 6 weeks, and she's still bothered. So we're going to talk about third-line therapies, but are there any other things that you would want to do with her at this point? So some person said, why do some young adults need to use the bathroom during the night, and how can they prevent from waking up the bathroom in the middle of the night? So yes, the next person said, don't drink anything before going to bed. Certainly avoiding drinking fluids 2 hours before bed can limit how much you wake up at night. Another question was, what are the risk factors of prolonged BPH in men? So if you have prolonged BPH, you can have worsening overactive bladder symptoms. You can have difficulty emptying your bladder, and you can, over time, that can create in and of itself bothersome symptoms, can make you wake up many times at night, or you can start getting bladder infections if you're not emptying your bladder well enough. And in very prolonged BPH, if your bladder's not emptying, your bladder can get so full that urine backs up into the kidneys and causes kidney damage. So those are issues that you need to be aware of. So Nabila said maybe increase exercise. Queen says, has she tried weight loss? Absolutely, these are great options. UUI is urgency urinary incontinence. My apologies for using acronyms. So yes, those are great options. She's she's over it and she wants to continue moving down the pathway. So let me pull back my slides here. Where did they go? Okay. So this is the next part of my algorithm for these patients. And these are third line therapies that we're going to talk about. We can do Botox injections in the bladder, sacral neuromodulation, and PTNS. So we're going to talk about each of these individually. So first one is percutaneous tibial nerve stimulation. And this is essentially like acupuncture. And what it does is you place a 34 gauge needle, which is really, really tiny needle, in the ankle where the posterior tibial nerve runs. And this nerve, if you look here, actually goes all the way up to the spinal roots that innervate the bladder and the sphincter. This is about 2 centimeters above the medial calcaneus and is medial aspect of the calcaneus, and it's connected to this low voltage stimulator device. And they come and you set it up and they will feel sometimes a sensation in their ankle or a movement in their big toe. And that's how you decide what stimulation to put them on. And they hang out in your office for half an hour. This was FDA approved in January of 2011. Typically recommends 12 treatments that are 30 minutes each for once a week. So it is a big time commitment for patients, and then maintenance monthly. This works about 60% of the time in helping urgency, frequency, and urgency urinary incontinence. And I've actually seen great results with it in patients who do stick with it and continue to follow up with the treatments. Next is Botox, which is also called onabotulinum toxin A. And what this does is it actually decreases muscle contractility. I got another question here. Is there a relationship between incontinence and menopause? So menopause can change the amount of estrogen that is in our body, and it can change the amount of estrogen that's in the vagina. And so that can cause some more irritative symptoms in women, because that can cause vaginal atrophy or dryness. And there is some data to suggest that there may be a relationship with worsening incontinence. However, treating with estrogen is not indicated for just incontinence at this time. And could urinary incontinence be correlated with women who've experienced abuse? Great question. So typically women who've experienced abuse will have pelvic floor dysfunction. And so because they've dealt with being, and men too, not just women. So anyone who's had abuse can have pelvic floor dysfunction as a reaction to dealing with that abuse. And that again can cause symptoms. The treatment of pelvic floor dysfunction is not all of these things I'm talking about. The treatment for pelvic floor dysfunction is seeing a pelvic floor physical therapist who can help teach you how to relax those muscles, because these are just band-aids for people who have pelvic floor dysfunction. They are not going to help you relax that pelvic floor for good. So back here to Botox. Botox decreases muscle contractility. So here you can see when there's no Botox present, acetylcholine, this vesicle connects to the bladder wall and releases acetylcholine, which causes bladder contraction. Botox actually connects to the receptor here where this acetylcholine vesicle binds and does not allow it to actually go into the bladder wall, and then inhibits that contractility. It basically causes paralysis of the bladder muscle that can last approximately 6 to 12 months. It lasts longer in the bladder than it does like on your face. And I'm not really sure why the reason that is. So the way we do this is typically in the office. We use numbing jelly that goes inside the urethra and the bladder. We go in with a camera and we inject small little doses of Botox throughout the bladder wall, usually 10 to 20 injections. People go home the same day. The big risk with this is that 5 to 20%, depending on the dose used, we start with 100 units, and the risk of urinary retention with that dose is 5%. So 5 out of 100 people will get so denervated or so affected by the Botox that they have difficulty emptying their bladder and then need to catheterize themselves. If they get a higher dose, like 200 units, the risk is much higher, like 20%, so 1 in 5 people. And if this works, they do need to be willing to come back to the office every 6 to 12 months. The next option is sacral neuromodulation. And so this is actually another type of electrical stimulation that is right alongside the S3 nerve root that stimulates the bladder. And what we do is we pass this tined lead right here with 4 little electrodes that goes alongside this nerve root. And then we attach it to a battery. And the battery stimulates the different tines on this lead that stimulates the nerve. And this is used to help restore normal bladder function. So it's actually indicated for more than just urgency, frequency, and urgency incontinence, which it works very well for about 80% of the time. And Botox also works about 80% of the time. It's also indicated for non-obstructive urinary retention. So people who can't pee, but it's not due to obstructions, due to a bladder that doesn't squeeze, or if they have fecal incontinence. So if they're having accidents with stool, this is also a treatment indicated for those who have failed medical management. And again, it sends this mild stimulation to those nerves to modulate bladder activity. And the patient feels this as kind of a buzzing feeling, and they usually get used to it. Initially in the beginning, they'll feel it, and then they kind of, it goes away because their body gets used to it. It's connected to a battery. That battery picture I showed you, it requires a change every 3 to 5 years. There is now a rechargeable battery option that you can connect to it, which then you just have to charge either once a week or once a month, depending on the type of neurostimulator you use. So there's two implantation techniques. There is a peripheral nerve evaluation, and this is done in the office under local anesthesia, and you place a temporary lead, not that tine lead I showed you, but one with just one point at the end, and you try it for about a week. And if it's successful, you then take them to the operating room for the implant. The other option is a staged procedure where they have their first the tined lead that I showed you, but it's actually attached to a battery that you wear around you for 2 weeks. And it's done under the OR, it's done in the operating room under local sedation. If it works, then you get the permanent battery, and if not, you don't. The nice part about this is that you get this trial period. So a lot of patients like that. And someone asked, how long would they need to get the Botox, or would they have to do it for the rest of their lives? Yes, if it's helping and they're getting relief from it, it is, in theory, something they may need for the rest of their life. If they find that it's helping and then they're able to lose weight, or some other things change in their diet and things get better and they don't need it anymore, then maybe they won't need it anymore. But it's definitely possible for those who have refractory overactive bladder. They've tried all these other things. They've tried to lose weight. They've tried to change their diet, that they may need Botox for the rest of their life. And back to sacral neuromodulation, success is defined as a greater than 50% improvement in patient symptoms. And I didn't mention voiding diaries, but voiding diaries are also really valuable in this patient population. So we actually give them these papers where they write down what they're drinking, how much they're drinking, and then we give them a way to measure their urine, and we have them write down what time they're urinating, how much they're urinating, if they're leaking, if they're having urgency, and keep a diary of it for 3 days. And that not only gives us information, because sometimes patients don't really know how to tell us or can't remember what exactly they're experiencing, it's also diagnostic for them, because they can look at it and say, oh, I drank a big iced tea in the morning and I went 10 times versus I drank water and I only went 3 times. So it can be really helpful for them. But we also use it after we do this trial to see if there's improvement. There are some side effects with this. There's a risk of wire movement if patients fall. I always tell them, do not fall. The device can have issues. It is a device after all, so patients can have pocket pain or issues with unwanted stimulation. They can now actually get an MRI. That's an old slide that I copied over here. So now we can get MRI. The leads are MRI compatible, so that's no longer an issue. So here's the current protocol. If they failed multiple OAB meds, if you have someone who doesn't want to have surgery, is willing to come every week, it really helps for nocturnal symptoms, so waking up at night. And you like seeing them, they like seeing you. They're the patient. A PTNS is a great option for them. If there's someone who doesn't mind coming in for repeat procedures, they really want to have symptom improvement for their urgency incontinence. They're not opposed to having awake procedures routinely. These who want immediate gratification, Botox is a great option. The last type is, again, I need to update this slide. They have a limited time availability, but they're willing to have surgery. And they don't want any of the other options. The one-time fixed patient is interesting. Next, a few more questions I wanted to answer. Is there a connection between UTIs and incontinence? So yes, urinary tract infections or UTIs can cause urinary incontinence. Because of the bacterial infection, people will notice that their incontinence is worse, or they will develop incontinence. And that will usually get better after treatment of the UTI. Sometimes people think they have UTIs because they have bad incontinence, but they may just have overactive bladder. So it's really important to check for the actual presence of UTIs by testing for urine cultures to see if they actually have UTIs. And then what kind of surgeries do urologists do? We do a lot of surgeries. So we can do, going from the top of the kidney, we do kidney tumor removals. We do take care of kidney stones that get blocked in the ureter with what's called ureteroscopy or nephroscopy, and then we use lasers to break those up. We can do prostate surgery, so we can do what's called transurethral resections of prostates, and then we can also do robotic surgery for prostate removal, particularly very often for prostate cancer. We can remove bladders and reconstruct them using bowel for bladder cancer, or for patients who have other neurologic issues or have really end stage or very big problems with their bladders. I do, as I mentioned, incontinence surgery, prolapse surgery. We can do surgeries for people who have urethral strictures or narrowings in their urethra. We can do surgeries on testicles for testicles that twist. We just do so many things that it would be difficult for me to go over all of them. But very commonly, the bread and butter of what most urologists do very often is kidney stones, prostate surgery, and then a lot of those cancer type things. Okay, so this 44-year-old female, we go back to her. We discuss third-line therapies. She really doesn't want to catheterize. She does not have the time to come to the office every week. She's got children, she's working. What is the best option for her? I'm going to answer some questions while I wait for you. If there is constipation for the patient, does that push on the bladder to cause OAB? Absolutely. Constipation is very much so related to overactive bladder symptoms, or even urinary retention. So I have patients who have urinary retention and they or urinary because their bowels are so backed up for years, they haven't had a bowel in like a week, and that actually causes it to make it difficult for them to empty their bladder. Yes, nerve stimulation, exactly. Another question was what made me go into this specialization? Well, I really liked surgery. Botox would not be the right answer because this patient doesn't want to catheterize, and they have to be willing to accept that 5% risk of needing to catheterize if they go through with third-line therapies. Because it's already 4 o'clock, I'm not going to go through stress incontinence, I just want to give you some advice, and my advice changes depending on when you see me or when you talk to me. But as of late, I've been telling myself you can do hard things, and I think this is really valid because in your course of getting into medical school or going through medical school, you will encounter things that you feel like are insurmountable. And believe in yourself, you can do it. Don't let imposter syndrome get to you. We all have it. I have imposter syndrome. People who are very successful, everyone has imposter syndrome. So Don't let that get you down. Believe in yourself. You can do hard things. And I really wanted to thank you guys for attending. I could answer maybe one more question. You can find out more about me on Instagram or Twitter. I also have my own YouTube channel where I do a lot of urology education, and I manage the South Asian Wellness YouTube channel, which is a bunch of physicians who educate on different types of medical conditions, which are valuable for all people, not just South Asian. So if you're interested in learning about that, please check that YouTube channel out as well. Any treatments for frequent UTIs, I would say check out my video on my YouTube channel about recurrent UTIs. I go through this in detail, and I have a lot of videos on many things urology related. I see, someone asked, what age range do I see the most? I see adults, but I see from anywhere from age 18 to 90 plus. In fact, I have a 101-year-old patient. So you can, in urology, you see lots of patients. I think the best thing about urology is that we get to do surgery and that we get to take care of patients in the long term. So I love urology. If you guys have questions about urology, feel free to reach out, because it is the best specialty. I love it. And I hope that you guys learn more about it. And if you have questions, reach out.
Thank you so much, Dr. Malik. This was a wonderful presentation. Everyone learned so much. Thank you for taking the time again to do this and to teach us all. And for everyone watching, the Google form has been posted in the chat box. That'll be open for another 30 minutes. So I'll close that at 4:35 p.m. Eastern time. And thank you again, Dr. Malik.
You're very welcome. Bye, guys. Thank you.